Hello and welcome to 5 Minute Science. Today's topic, familial combined hyperlipidemia. So what is familial combined hyperlipidemia? Let's break it down. Familial, meaning related to family, so it's a genetic disease. Combined, because it includes two different issues, and hyperlipidemia, because it involves elevated blood lipids. Today's disease is the most common of 6 different familial hyperlipidemia diseases. These can be tabulated to show their name, which lipoproteins have been elevated, which classification they fall under, and how common they are. Today's disease involves elevated LDLs and VLDLs, classified as class 2B and is the most common of the diseases. FCH is a chronic disease, and as a result of continually elevated LDL and VLDL levels, those who suffer from FCH have an increased risk of premature coronary heart disease, myocardial infarction, atherosclerosis, obesity, type 2 diabetes mellitus, and unsurprisingly, they have a reduced life expectancy. It must be time we discuss the etiology. As mentioned, this is a genetic disease, but unfortunately, the exact genetic defects are currently unknown. There are 35 different genetic defects which have been linked with FCH. These include mutations in the APOA1C3A4 gene cluster, LPL D9N and LPL N291S mutations, chromosome 1q21, q23, and more recently USF1 and APOA5. So who is affected by FCH? An estimated 0.5 to 2% of people suffer from FCH, amounting to approximately 100 million people worldwide. Despite the high prevalence of the disease, there is an acute shortage of research into the occurrence across demographics. There are currently no studies comparing incident rates among Indigenous Australians and non-Indigenous. There are also no conclusive studies to determine if one sex is more susceptible. However, there are numerous studies that show males to have more comorbidities and generally a greater elevation of the LDL and VLDL levels. Future studies are required, but being a genetic issue, you would expect there to be variances in occurrences across people groups depending on their genetics. It's almost time to look at the pathophysiology of FCH, but first we need to understand how lipid metabolism should work in a healthy individual. Lipid metabolism is divided into 4 distinct phases. Phase 1, lipid digestion. After fats have been eaten, the body uses several different lipases to break down the triglycerides into fatty acid units, ready for absorption. Lipid absorption. The fatty acids can cross the intestinal membrane where they are recombined into triglycerides. These triglycerides are combined with cholesterol and phospholipids to form chylomicrons. 3. Lipid transportation. Because lipids are hydrophobic, they require transporter proteins to help them travel through the bloodstream. Chylomicrons, LDLs, and VLDLs are all transporter proteins. 4. Lipid catabolism. Once the transporter proteins have reached the target area, they are broken down by lipoprotein lipase and release the associated triglycerides and cholesterol. The triglycerides are again broken into their subunits prior to cell absorption, and the cholesterol is returned to the liver. So what was wrong in FCH? Well, stage 1, lipid digestion, is fine. There are no problems digesting lipids. Stage 2, lipid absorption, it's also fine. There are no issues absorbing lipids. Stage 3, lipid transportation, is where things start to change. People suffering from FCH have highly elevated phospholipid concentrations. Whilst the exact mechanism is unknown, APOB is heavily overproduced. APOB is a major protein component of both LDLs and VLDLs, and as a result of its overproduction, people suffering from FCH have a very high APOB to cholesterol ratio. This means that LDLs and VLDLs are overproduced proportional to the actual needs. Stage 4, lipid catabolism, is also an issue for those with FCH. The breakdown of LDLs and VLDLs is dependent on lipoprotein lipase. FCH causes a significant reduction in the activity of lipoprotein lipase, meaning that the LDLs and the VLDLs can't be broken down. When you combine the issue of excess production and you pair it with reduced breakdown, it becomes clear why the levels are so high in people with FCH. So how does FCH present? FCH typically presents with weight gain, particularly around the waist, but can often be asymptomatic at first. Blood tests will reveal elevated LDL and VLDL levels, and more comprehensive testing can reveal elevated APOB concentrations. Older individuals with FCH will present with comorbidities because of the strong link between FCH, type 2 diabetes, and cardiovascular diseases. Unfortunately, diagnosing isn't as simple as it sounds. Studies have shown up to 40% of patients can be misdiagnosed when the initial diagnosis is based on a single observation. Additionally, despite being a genetic disease, genetic markers are often an ineffective method of diagnosing because of the diversity of mutations. Current recommendations are to use a nomogram, thus ensuring multiple variations are considered and reducing the likelihood of misdiagnosing. Unfortunately, an accurate nomogram requires comprehensive data from different ages, sexes, and people groups, meaning diagnosing minorities and children can be difficult. Thanks for joining us on 5 Minute Science.